My name is Asim Desai. I'm a cardiac electrophysiologist, so I'm a cardiologist that specializes in heart rhythm disorders, essentially an electrician for the heart's electrical system. My colleagues, the interventional cardiologists, deal with heart attack patients, open up blocked arteries. As electrophysiologists, or EPs, we specialize in rhythm disorders such as atrial fibrillation, which is what we'll be talking about today. And we have access to a variety of amazing technologies and are blessed that Mission Hospital and the donors have been generous in funding these programs for us. So the title of the talk is A Patient's Journey from Arrhythmia Diagnosis to Treatment and Recovery. And we'll start off with an introduction. There are 3 electrophysiologists at Mission Heritage Medical Group. We call ourselves Heart Rhythm Specialists. HRS is the name of our group. There's myself, Dr. Lin Hung, and Dr. Jay Tiangson. And at any point, we encourage you to contact us. There's a variety of different ways to do so. If you ever have any questions or want to consider patient care related issues, we'd be happy to help. In terms of contacting us, this number, 347-2822, is probably the best number, and we can certainly provide some other contact information after the talk. So let's talk about Esther. She's a very, very sweet lady. She's from Germany, and she happened to be our 1,000th robotic ablation patient. And so I'm going to just tell you her story to introduce some of these concepts that we're going to be talking about. Esther's an 80-year-old female with hypertension and highly symptomatic persistent atrial fibrillation on medical therapy referred for evaluation. Persistent AFib means AFib more than 7 days, and there's 2 kinds. There's persistent, which is less than a year, and there's long-standing persistent, which is greater than a year. In Esther's case, we believe it was for less than a year based on symptoms. So she was actually referred by a cardiologist at Hoag who knows about our robotic ablation program. We're one of the few in California and wanted Esther to get that technology. So that's how she ended up at Mission. The EKG, the electrocardiogram done in my office, which is an electrical recording of the heart, showed an irregular heartbeat in what we call a narrow complex tachycardia. That's just a way of saying a fast heartbeat with no visible P waves, the P waves being the electrical signature of the atrium contracting normally. So when you see those disappear, that's the hallmark of atrial fibrillation. She's failed drug therapy. These are some of the more common ones used. Amiodarone is actually the most effective, has many toxicities, and she even broke through on amiodarone with her episodes. Failed sotalol, failed diltiazem. Part of the workup of any arrhythmia patient includes measuring the heart structure. So the heart is an engine, and it has an electrical system, and it has plumbing, and it has valves. And so we look for any signs of structural heart disease when we're evaluating a rhythm problem because it carries different prognoses. If you have structural abnormalities, then the prognosis typically is worse versus if you have no structural abnormalities. But we have ways of treating all of these patients now. So she has normal heart function, normal squeeze of her heart called the ejection fraction, no significant valvular heart disease, and she's had prior stress testing that's shown no significant coronary artery disease. Here's an example of Esther's EKG in the office. These are the heartbeats, the individual heartbeats called the QRS complex. She's going around 120 beats per minute, and keep in mind, she's already been sitting in the office for about 15 minutes. Resting heart rate 120, so you can imagine when she's walking around, even around the hospital, her heart rate's shooting up to 180. And here we do not see any clear P waves. So the P wave would be located in between these sharp spikes, and you should see a little hump, and we don't see that. So it's irregular, and we don't see any visible P waves. So for all intensive purposes, this looks like AFib. But the gold standard way to assess the electrical system is what's called an electrophysiology study. Similar to an angiogram, where you inject dye in the arteries to look for blockages, the EP study is done in the same way, and in fact, we go through the femoral vein down in the leg, so it's a lower bleeding risk than going through the femoral artery, which is what you do for angiograms. And the electrical system sits right in the middle of the heart and inside the heart muscle. So you have 4 chambers, the right atrium, the left atrium, the right ventricle, and the left ventricle. And believe it or not, any of these 4 chambers have the capability of creating abnormal heart rhythms because the cells within the heart have electrical capability. And so your normal heartbeat, if you look up here in the corner of the slide, starts up in the sinus node in the right atrium. AFib originates from the left atrium, the top left chamber. So we put catheters up into the heart and we can actually record the electrical signal. And that's what you see down here. On the top, you see the EKG, what I just showed you that's done in the office. We have that hooked up to the patient. And in blue are electrodes that are sitting in the heart. Electrodes measure the local electrical signal as it moves through the heart. Best way to think about abnormal heart rhythms, also called arrhythmias, is they're like storms. They're like tornadoes or hurricanes. And what we're looking for is we're looking for how that hurricane moves from point A to point B. And we use a variety of different technologies to assess that. Once we identify the eye of the hurricane, the critical part of an arrhythmia, then we deliver a variety of different energy technologies, radio frequency or heating the circuit, or cryo, freezing the circuit, for example. The technology we'll be talking about today, Stereotaxis, is a robotic ablation system that uses radio frequency energy, but the big difference is rather than using the human hand, we use magnetic fields that are driven by a computer-mouse interface. So on the bottom here, what you're seeing is each one of these spikes is a single heartbeat going through the atrium, the top chamber. So normally it should be something like a beat here, a beat here, a beat here. That would be like 60 beats a minute type of thing. Here, this is going about 300 beats a minute. You can see it's going really fast. And what we notice first as an electrophysiologist is AFib, when we look at these signals, it should look like noise. It should look like total electrical noise, nothing organized. But instead what we see is we actually do see discrete, organized signals. And I hope you can appreciate that. So right off the bat, I realized we did not diagnose AFib. She, in fact, has something called atrial tachycardia. And the thing about rhythm disorders is they're masqueraders. They're tricky. And a 12-lead EKG in the office is only a bird's eye view. And so we've seen cases where you think someone's in AFib, but actually it's in a different rhythm. And this one is called atrial tachycardia. And in fact, at the beginning of this procedure, when we put the catheters in, sometimes that can stimulate the heart, and it stimulated it so fast, her heart rate went almost 200 beats a minute. And so in the beginning of the procedure, we actually had to cardiovert her or shock the heart back into normal rhythm in order to take our time in assessing the heart function. When we do the mapping of an abnormal short circuit, think of this as like an angiogram for the blocked arteries, but this is the way to do it for the electrical system. And we use three-dimensional technology. It almost looks like a paintbrush, multiple catheters around it, and we essentially paint the inside of the heart. And these electrodes have the ability to record the local electrical signal, and we measure the size in millivolts, and it translates it through an algorithm to color. And so the color means different things in different scenarios. And just think of us as like a pilot, and we're sitting in this cockpit, a variety of different screens in front of us, and we're integrating that information in our heads to decide the next step. This is called three-dimensional electroanatomic mapping, or 3D mapping. And on the left, this is what we call an activation map, which is essentially, if you remember that hurricane analogy, we're looking for the eye of the hurricane. And in this case, that red spot, that's the eye. That's where the circuit was coming from. On the right tells us the health of the tissue. It's called a voltage map. So on the left, we're measuring the sort of movement of the abnormal rhythm. On the right, we're looking at what we call the substrate. What is abnormal in the tissue that could be contributing to that? And I hope you can appreciate there's a lot of abnormal colors in here. You see green and all sorts of colors compared to purple. Purple is healthy. So you can see there's actually an area in the tissue that's abnormal, and that's what's generating the abnormal circuit. This is what I meant by painting the inside of the heart. I like to call it painting the cardiac canvas. So these are three different catheters that are used, different companies make them, to record the electrical signals. And you can see these tiny little electrodes take that information, convert it over to color, and we're able to, while the heart's beating and the patient's breathing, paint this cardiac canvas. And this just shows you kind of an analogy to what I'm talking about. So on the right is an example of an AFib ablation where you can see the catheter hidden down here. That's what we're looking at here, called the pentaray. And I move it around the heart and it collects the information, and you can see it starts to create this color map. And what we're looking at here is a back view of the heart if we were standing behind the heart. And this is the left atrium. So this is where AFib originates from, these four structures called the pulmonary veins. They're veins, they're almost like castles of AFib that send out abnormal impulses to trigger this rapid irregular rhythm. And what we do with ablation, for example, is we create a line of insulation to prevent those impulses from getting around. That's a general principle in any of the heart rhythm procedures that we do. What I'm showing you now is not Esther's case. I'm showing you just an example of an AFib ablation. But if we get back to Esther, here's a close-up shot of that eye of the hurricane, of that condition, atrial tachycardia, very similar to AFib. And this is an example. What you see here is actually a direct recording of that red spot. What you see here is a recording in another area of the heart. So you can see this is healthy tissue, and I don't know if you can appreciate, but there is a very, very small, really kind of noisy looking signal. That's real, and that contributes to what's going on there with the rhythm. This is called a three-dimensional animation map, and it's coherent technology made by Biosense Webster. So we not only can see in still frame like I showed you, but we can see in real time. This is the eye of the hurricane, and it really looks like a weather map. This is the eye of the hurricane, and that's how it moves through the heart. And so when I started training in electrophysiology back at Stanford in 2001, all we had was X-ray. We didn't have any of this three-dimensional mapping, so it's come a long way. This is another type of map. You're looking at the exact same structure. You're looking at Esther. This is the left atrium. This is the right atrium, and the ventricles would be down here. That's how your heart would be sitting in your chest. And in this case, again, what we're looking at, and if you can appreciate, there's a whole burst of white signals that come out and then move. So you can see right there, burst and then it moves. That's called a ripple map, and it tells us additional information. So then we did the mapping. The mapping is actually the most critical part of any kind of heart rhythm ablation procedure. Then we go to the ablation, and we have different technologies that we can use. In this case, Stereotaxis, there's less than 200 hospitals in the world that have this system. And we're very fortunate through the donors, through Mission Hospital, to fund the system. And it's an amazing piece of robotic technology, different really than any other robotic technology out there. It utilizes magnetic fields to move the catheter through the heart, and is truly incredible. And I would invite any of you to check out the Mission Hospital website, the cardiology website, and we can certainly make arrangements if you ever wanted to see things further. We can get you contact information if you want to learn more about the technology. So through the same entry point into the femoral vein down in the leg where I put the catheter, I take the mapping catheter out and then I put the ablation catheter through it. So when the patient leaves the hospital, you can't even tell they had anything done. There's a Band-Aid over the groin area. That's where we go in. So this is, people are going home the same day. It's amazing how minimally invasive it is now. And so I go in with the robotic catheter and I go to the area, to the hot spot, and ablate it. I deliver radiofrequency energy. So what you're seeing here is what I showed you on that other tracing, that this is a heart in the atrium. It's going 300 beats a minute, 1 beat, 2 beat, 3 beat. So 300 beats a minute, that's her problem, that's the hurricane. As soon as I deliver the heat from the catheter, from the robotic system, you see immediate conversion to normal rhythm. So that's a normal sinus rhythm. It was very gratifying to see this for Esther. And so here's a different view, a different type of map. This is with the robotic system, and it shows you the head of an arrow. So imagine that there's an arrow here, and that's the head of it. That is what I click on with a computer mouse, and I move it in different directions to tell these magnets that rotate around the patient which direction to move the catheter. This just shows you what Esther looked like the next day, and you'll have to take my word for it. The day before the procedure, she was on a bed, extremely short of breath. So we got a big smile here the next day on same-day care unit. And so to transition to AFib, most common heart rhythm disorder worldwide, 1 in 4 of us, so for those of us who are on this call, 1 in 4 of us over age 40 at some point in life will get AFib. It's arthritis of the electrical system. Scar tissue builds up and creates these circuits. The atria, the top chambers, beat rapidly and chaotically. Blood doesn't move well, forms a clot, causes a stroke. That is the most catastrophic aspect of AFib. The second most catastrophic aspect is heart failure. With the heart rate going so fast, it can weaken the heart muscle. But the good thing is, if you correct the rhythm disturbance, in many cases, the muscle actually gets stronger again. And reduce quality of life. People with AFib can have a whole host of symptoms. It's a very, very subtle disease, very difficult to diagnose in some cases. Most importantly, take away from this talk today, it's a progressive disease. AFib begets AFib. Every episode of AFib that someone has, even if it's for a few minutes, changes the cells in the heart, creates a muscle memory in the heart muscle to want to have more AFib. But the same goes true if you can get someone into rhythm and keep them in rhythm. Normal sinus rhythm, which is the normal rhythm of the heart, normal sinus rhythm begets normal sinus rhythm. It doesn't matter how we get there, if it's ablation, if it's a drug, if it's a device, if it's a combination, it's all about getting into rhythm and staying in rhythm. So early detection and early intervention are critical with AFib. We used to be thinking in the past that, oh, if you only had a few episodes a year, it probably isn't going to cause anything. That's not true now. We know this disease progresses with every episode. That's why Apple, that's why other companies have ways of detecting AFib with EKG recordings that people can purchase over the counter and give to their doctors. So there's some pretty amazing wearable technology now to diagnose AFib. And the symptoms can range anywhere from palpitations, which is a rapid irregular heartbeat sensation, your heart's pounding, lightheadedness or dizziness. You can have trouble breathing, short of breath. You can have chest pain or chest pressure because the heart's not getting enough blood. And one of the more common symptoms we see is fatigue. So with AFib, I mentioned it's progressive. In the beginning, paroxysmal. You go in and out of AFib. That's what early AFib is called, PAF, paroxysmal AFib. As the disease progresses, you go into continuous AFib, persistent AFib, and that's what Esther was diagnosed with previously, persistent AFib. And when you transition, the symptoms typically go from this palpitations to the fatigue. So there's so many reasons why we may be tired. We didn't sleep well, we're on medication, a whole host of reasons. What we really want to enforce to people is learn how to take your pulse in your carotid artery in your neck, in your radial artery in your wrist. Learn how to take your pulse. It should feel like a metronome, nice and regular. And if it's not, it could be a sign. It could be a sign of AFib. That being said, there are other rhythm issues, benign rhythm issues called premature beats that can sometimes simulate an irregular heartbeat. So it's always important to get a medical evaluation by your doctor. But we see very commonly people show up for a pre-op for gallbladder surgery. They're in AFib, had no idea. And when you really start to talk to them and say, yeah, doc, over the last 6 months, I've been feeling more tired. That's the symptom of AFib. When we restore the rhythm, that fatigue gets better. Silent AFib is AFib where you have absolutely no symptoms, and it's an enormous cause of stroke. And it's a cause of cryptogenic stroke, which means stroke without a clear etiology. When people come in with a stroke to the hospital, like Mission Hospital, top stroke center, about 30% of people will have a stroke and we have no idea what caused it. They're in a normal rhythm when they come in. There's no blocked arteries in their neck or in their brain. Their blood pressure is controlled. Well, it turns out that they may have been in AFib for 5 hours at home. That clot went up to the brain and caused a stroke. So this is a big focus now, is looking for silent AFib, and we have technologies to help with that. These are the risk factors for AFib. There are many more, but if you take anything away, age is the number one risk factor, age over 65. Obesity is a significant risk factor. High blood pressure, diabetes, sleep apnea is a very significant unrecognized risk factor. So many people who get AFib and we can't figure out why. Sleep apnea is a big cause where you stop breathing at night. And sleep apnea doesn't have to involve snoring. You can have central sleep apnea where you just stop breathing and you may have no idea, or your spouse or your partner may have no idea that that's actually happening because you're not snoring. Thyroid disease, alcohol. So alcohol is a big trigger for AFib. In fact, one glass has an 8% chance of triggering an AFib episode. So people used to think heavy alcohol use. Well, it turns out that if you're at risk for AFib, just a little bit of alcohol goes a long way in a bad way. And with COVID and the increased alcohol sales, we're seeing a lot of people getting AFib from weight gain, from alcohol. Anything structurally in the heart, coronary artery disease, bypass surgery, stents, valvular heart disease, valve replacements, those all put people at higher risk for atrial fib. Everything is interconnected in the heart, everything is interconnected in the body, and that's what we see here. When we treat AFib, we have to treat the whole patient in an integrated fashion, treating all the risk factors to have the best outcome. So when you hear about people who get different AFib treatments, ablation, et cetera, and it didn't work, that it didn't work statement, in many cases, it's because the risk factors were not treated. This is not just a disease that you cauterize and you're done. You have to lose weight. You have to have all these other risk factors treated. There are a lot of studies now that have shown better outcomes treating the risk factors. So here's a graphic: paroxysmal, early onset AFib, then you go into persistent, then you go into long-standing persistent. There's something called permanent AFib, which means people are living in AFib. That is more of a decision-making that a doctor and patient make together, that if they've tried different treatments and they feel the risk of treatment is greater than the benefit, then we allow patients to live in AFib, but we're still treating them. We're preventing stroke, we're controlling the heart rate, so these patients do get treatment. What's striking, though, is 20% of patients progress from early onset AFib, paroxysmal, to persistent, continuous AFib within a year of their AFib diagnosis. So by the end of a year, 20% of those patients will actually have gone from, I call it electrical cancer, early electrical cancer, to metastatic electrical cancer within a year. It's striking. It's a very subtle disease. And if you look at the data, 6 million Americans now have AFib. It's projected to be about 16 million in the year 2050 because of aging. Obesity is a big contributor as well. All of these numbers, less than 10% of these patients are actually getting proper treatment for their AFib. And a lot of it has to do with education. AFib is a very complicated disease. It is very hard to keep up with the treatment as a physician. And unless you're dealing with AFib every day, like a cardiac electrophysiologist, many of our cardiology colleagues have a lot of experience with AFib, you're not going to know about the latest treatments. And so now paroxysmal AFib has a treatment success rate with ablation, for example, of up to 90% now, and it used to be 40%. So be very careful. A lot of misinformation out there about AFib, coming from a variety of different sources. Always consider seeking out expertise, cardiologists, cardiac electrophysiologists. We can be approached now, people can be directly referred to us as electrophysiologists in many cases. And so a lot of misinformation, so be very careful about that. This is a slide that just illustrates some of what I've already said, that the prevalence of AFib increases with age. So in your 50s versus in your 80s, your prevalence goes up significantly. And here's that graphic I was showing you about going from 6 million to 16 million over the course of just a few decades. Stroke is the biggest concern, the biggest catastrophic consequence. We have risk factor scores for determining who is at high risk for stroke, who should be on a blood thinner, or considered for other types of procedures that can be used to treat stroke. And what's someone's risk of bleeding on a blood thinner? And the stroke risk score is called a CHADS-VASc. The bleeding risk score on a blood thinner is called HAS-BLED. These are acronyms, and you literally can Google this. You can go online and you can calculate your risk of stroke and your risk of bleeding with and without treatment. So it's a nice scientific way of doing it. Healthcare, the healthcare industry, major expenses related to AFib. People are getting hospitalized. About 750,000 people a year in the US get hospitalized for AFib. And it then leads to stroke, which leads to multiple hospitalizations, longer hospitalizations, multiple treatments, and then also congestive heart failure, which is one of the top admission diagnoses. So very, very important to our healthcare system. Again, the diagnosis, this is what a normal rhythm looks like on the bottom. You see that little hump, the P wave, the atrium contracting. We see the QRS, which is the ventricle contracting, one-to-one fashion, top to bottom, lub-dub, the heart beating normally. Here we see multiple irregular heartbeats and that noise that almost looks like electrical artifact. That's AFib. And we have many ways of diagnosing it. We have monitors that you can get from your doctor's office. You can wear them for 24, 48, 2 weeks, 4 weeks, even 3 years. There's an implantable monitor that's good for up to 3 years. That can detect silent AFib. It's an amazing device. Through cell phone networks, someone can be in Italy when we're all allowed to travel again. Someone can be in Italy, have an AFib episode. The data, if they're in a cell phone area, can get transmitted to me in the office, and I can know about their AFib, and we've actually had that happen. And so it's really amazing. And now I mentioned Apple, and there's another company, AliveCore, which makes the Cardia mobile device. These are wearable consumer devices that you can actually, they're FDA approved. You can actually make a diagnosis of AFib. They're not perfect by any means, and I really caution people about that. You should always discuss this with your healthcare provider if this is a reasonable thing for you to get, and how best to use it, and how to communicate the information. So don't just rely on the technology, but it puts the power back in a person's hands, that they're able to figure out what their heart is doing. And so AFib, I mentioned there's a couple of different treatment options, not just a couple, many, but we first look at controlling the heart rate, protecting against stroke, and then we look at restoring the rhythm. And more people were trying to restore the rhythm. There are cases where it doesn't make sense to restore the rhythm if someone is very high risk for different procedures. We have drugs. We have a procedure called cardioversion where you shock the heart. We have ablation where you basically repair the broken insulation around the AFib broken wire, so to speak. And so of all the treatments, studies have shown ablation is the most successful, hands down. There is a role for drugs. This table, this is meant to be a busy slide. It just indicates drugs to control the heart rate. That includes beta blockers, that includes calcium channel blockers, digoxin, antiarrhythmic drugs to help keep people in rhythm, including flecainide, propafenone, amiodarone, sotalol, Ticastin. You may have heard of these names. And then the stroke prevention, all the drugs that we have, warfarin or Coumadin, Xarelto, Savesa, Pradaxa, Eliquis, these are all different blood thinners that can be used. And now we have a great group of technologies that allow us to basically section off the left atrium, the left atrial appendage, which is the source of blood clot in the setting of AFib. We have ways of actually sectioning it off from the rest of the body. So the clots that form in this structure, this is the left atrium, right ventricle, left ventricle. We can actually put devices in or outside of the heart that protect against stroke, that allow people to get off blood thinners. And there's definitely opportunities for that. Lariat, Watchman, and AtriClip. And our surgeons at Mission Hospital, our cardiothoracic surgeons, Dr. Darbinian, Dr. Thibault, Dr. Tang, they actually can do this AtriClip procedure. They often do it as part of other procedures. Watchman we're going to be getting soon at Mission Hospital, and Lariat we've also done. So with ablation, I already talked quite a bit about it, but let's go into a little bit of the details. These are the different technologies. This is cryo, we're freezing the heart, we use a balloon. This is radio frequency with a manual catheter where we heat the tissue. This is the robotic I'm going to chat about, where we use magnetic fields around the patient. And convergent, we were the first hospital on the West Coast to do this ablation, which is a hybrid ablation that you cauterize both the outside and the inside of the heart. I already talked about this, that ablation therapy in the studies far superior to drug therapy. This is an example of the robotic system, Stereotaxis. The magnets come in, the patient is lying on the table, and then what'll happen is I can control these magnets just sitting at a desk with a computer mouse. So there's actually a technology called Telerobotics. Because the data gets to the magnets from a computer mouse interface through high-speed telecommunication lines, I can actually control the magnets remotely. So I've been able to sit in my office on Crown Valley Parkway and control the magnets in St. Louis, where Stereotaxis headquarters are. There was a doctor in Milan, Italy, that was able to control the magnets and do a remote ablation on a patient in Portugal. So that reality is here, called Telerobotics, and hopefully Mission can get involved in the process as studies are being done, because we do have the system in place. This just shows you an example. The doctor would sit here, look at the screen with the information, the patient's here. Usually anesthesiologist, the nurse is by the patient, closely monitoring. And then here you can see the Mouse directs the catheter, which directs the magnets, which then directs the catheter. So the mouse moves, you click on this arrow, this is a picture of the heart, that tells the magnets which way to go, magnet shift, and then the catheter, this is the catheter, it has these dark blue dots, and those are the magnets in the catheter. So it's that 4-step process. Another way to think about it is on your refrigerator, if you had 2 magnets, a small one, a big one, you move the big one around, the small one follows. That's essentially what we're talking about. So you can imagine that that magnet is around the patient and that catheter is in the heart, and these magnets are attracted to that magnet, and all we have to do is control the way those magnets move. This technology is amazing. This is a variety of different things going on. Let me orient you. Top left, this shows the precision of the system, 1 millimeter precision in movement. We're controlling the catheter and able to hit each of these targets. Stability, so on the right is a manual catheter, human hand holding. You can see this is an example in a science lab where the heart is beating and the catheter is bouncing off of it. And to get a good ablation result, you have to have good tissue contact. That catheter really needs to be in the best contact with the tissue. One of the reasons why AFib ablation hasn't worked for people is that you didn't get good lesions, you didn't get good contact, you didn't have the right technology. And that's because we didn't have those things years ago, and things have gotten so much better. But with the Stereotaxis system, you can see here, the catheter is sticking to the tissue with every heartbeat because the magnet is around the patient and it's pulling the catheter right to the tissue. Here we can see down in the lower left, the catheter can do all sorts of twists and turns. It's ultra soft. We don't have to have a stiff cable in it. With a manual catheter, think of it as like writing your name with a pencil but using the eraser. I have to have a stiff cable in the catheter for me to be able to move the tip of the catheter that's in the heart down from the leg where the controls are. Well, with the robotic catheter, I'm writing with the tip of the pencil. I'm controlling the tip of the catheter with magnetic field, so I don't need a stiff catheter. That catheter can be like overcooked pasta, and you can move it through the heart. And actually, for ventricular arrhythmias from the bottom chamber, it's one of the best approaches because there are many areas in the heart we can't get to easily with the human hand, and this has just been a game-changing technology. Mission Hospital's Stereotaxis system, we've had it since 2011, and we just celebrated, as I mentioned, 1,000th robotic case with Esther. There's a lot of good data on the safety. You have the precision, you have the soft touch that it cannot perforate or damage the heart muscle like a manual catheter can. You don't have to use X-ray when you use this catheter or that much X-ray. Because of the technology built in the 3-dimensional mapping. So that's kept patients safer, physicians safer, less X-ray exposure. And so it really made a difference. And there are studies, many studies, what you're seeing here, these are busy slides. It's just comparing manual versus robotic ablation. And these are all the sort of complications like making a hole in the heart, cardiac perforation, for example. You can see robotic, much less of that than manual. And the only reason why you would get a perforation with robotic is from the heating, is not from the catheter itself. Equal efficacy in many different studies. And so the treatment of AFib, it's really treating the entire patient, the mind, heart, body connection. I didn't go into this, but lots of interesting information about the nervous system and how it plays a role in arrhythmias. I'm a big believer in meditation and mindfulness. We definitely see stress as a big trigger for our patients. The healthcare team, our nurses, our medical assistants, our physician assistants, our internal medicine, our cardiologists, and then we have our sleep specialists for people with sleep apnea. It needs to be a team, and weight loss is so critical as part of this. So again, this is the way that if you'd like to get in touch with any of us at Heart Rhythm Specialists, Mission Heritage, we can provide that information as well on different websites. I mentioned that AFib, there's a lot of misinformation. And one day I was walking out with one of my patients, and he was in AFib for 5 years continuously, has been told by multiple people, nothing could be done, in it too long, metastatic electrical cancer. Through technology and techniques at Mission Hospital, we got him into normal rhythm. He was in a normal rhythm walking out, and he turned to me and he teared up and he said, Dr. Desai, thank you for taking me on this journey. And when people told me nothing could be done, I just wish there was an easier way to have gotten here. That's why I wrote a book called Restart Your Heart. It's out now. It just came out. September is National AFib Awareness Month. So this is a playbook for patients, for healthcare providers, to give some integrative, holistic kind of guidance in this disease, including all the technologies that we talked about, but also all the risk factor and lifestyle components. And for anyone who has any questions, I'm on social media. You can reach me obviously through the hospital. I have a website. I'm on social media, and definitely have a lot of content out there on heart health in general. So I'll go ahead and stop here with the talk. I know that was a lot at once, and see what kind of questions we have.